Independent medical practices are operating inside a mechanical vice, with dual financial pressures steadily compressing their operating margins from both sides. According to Kodiak Solutions, healthcare organizations collectively lost $48.4 billion in net revenue to final denials and uncollected patient amounts in 2025 alone. An upward line shows a 25% increase in claim denials, intersecting a downward trend in payer reimbursements. This pressure comes from the 2025 CMS physician fee schedule, where the Medicare conversion factor dropped 2.83%, from $33.29 to $32.35. Clarivate data reveals exactly where the friction starts. 1 out of every $8 billed to insurers is instantly rejected upon initial submission. A primary driver of these instant rejections is medical necessity denials, which rose 5%, specifically targeting emergency care and telehealth services. Caught between rising denial rates and shrinking per-encounter payouts, practices relying on manual, outdated billing processes operate with a negative margin of error. The root cause of these billing failures originates in the back office, specifically driven by the continuous churn of administrative staff. The Medical Group Management Association established a baseline annual turnover rate of 33.3%, specifically for billing and business operations support roles. Recent polling confirms this operational strain is intensifying, with 29% of medical groups experiencing even higher staff turnover in 2025 than the year prior. Replacing a single frontline biller directly costs a practice between $9,000 and $12,000. While that covers recruitment and training, it completely excludes the invisible revenue leakage, unworked denials, and missed submission windows occurring while the desk sits empty. Filling that empty desk is proving difficult. 59% of practice leaders report that finding qualified billing candidates is a worsening challenge. High turnover mathematically guarantees that the highly specific, payer-level institutional knowledge required to get claims paid systematically walks out the door every few months. For out-of-state or inexperienced billing teams, Michigan presents a hidden regulatory trap. On the surface, the state appears accommodating, offering a generous 12-month timely filing window for Medicaid fee-for-service claims. In practice, relying on that rule will bankrupt a clinic. Most Medicaid patients in Michigan are not actually processed through standard fee-for-service. They are enrolled through specific privatized managed care organizations, or MCOs. While the state regulation stretches a full 12 months, it is abruptly cut off by individual MCOs enforcing their own internal deadlines. A claim submitted at month 6 is perfectly compliant under state law, but is fatally denied by MCO rules. Missing an MCO deadline generates a denial that completely bypasses the standard state appeal process, leaving the practice with zero recourse. Treating Michigan Medicaid as a uniform set of billing rules systematically hemorrhages revenue to technicalities. The second major hazard in Michigan billing is the completely isolated ecosystem governed by the Workers' Disability Compensation Agency. The 2025 Healthcare Services Rules dictate exactly how these claims are paid, strictly enforcing a Maximum Allowable Payment, or MAP, schedule. The MAP rules are dense, requiring billers to navigate 7 distinct calculation methods based entirely on service category. Providers must accept the calculated MAP rate and are legally barred from balance billing the patient for any remaining difference. This 28-day provider selection clock is a critical operational hazard. During the first 28 days, the employer directs treatment. After that window closes, the patient can shift providers, entirely rerouting the billing relationship mid-treatment. Folding complex workers' comp claims into a generic daily billing queue guarantees missed transition windows and heavily misrouted claims. Protecting margins requires abandoning generic workflows and adopting the data-driven habits of high-performing practices. Healthcare Financial Management Association benchmarks demonstrate that organizations operating dedicated revenue integrity programs realize a 68% improvement in net collection rates. The primary hallmark of these top performers is their submission architecture. They utilize highly customized, payer-specific submission protocols rather than standardized billing templates. They mandate strict front-end eligibility verification before every patient encounter, eliminating upstream coverage denials before a claim code is ever generated. They execute aggressive, dedicated accounts receivable follow-up, governed by rigid escalation triggers to prevent aging. This discipline results in the gold standard operational metric, maintaining overall denial rates below 5% and keeping total days in AR strictly under 40. Surviving the density of Michigan's billing rules requires treating every single payer as a distinct, specialized operational pipeline. A growing number of Michigan practices are resolving this complexity by outsourcing the entire function to Staffingly's hyper-specialized, state-specific remote teams. The model deploys AAPC and AIHEMA credential specialists who work natively inside the practice's existing EMR every day. This human expertise is reinforced by AI-augmented tools, utilizing smart routing and predictive workload management to prevent claim backlogs from ever forming. The financial math is clear. An in-house Michigan biller's fully loaded cost, salary, taxes, benefits, and turnover sits between $55,000 and $75,000. Staffingly inverts that cost. Dedicated seats operate at $399 weekly, totaling exactly $20,700 annually. This structure provides direct annual savings of $34,000 to $54,000 per seat, while simultaneously upgrading the operation with credentialed billing experts. Deployment is highly efficient. Practices achieve complete EMR connection, initial team training, and full workflow go live within 14 days. The service operates with high flexibility, eliminating long-term contracts in favor of month-to-month scoping immediately following the pilot. If a team member requires replacement, Staffingly executes the transition seamlessly within 48 hours, fully protecting the continuity of the revenue cycle.